Thank you, Professor Wu. I think that Professor Liu already answered all the questions. Just follow the NHA reimbursed criteria. That's the how to redefine our liver cancer care. Okay, so we know that TSC is the mainstay for unresectable HCC. If the patient cannot get the curative treatment, this is the BCLC 2022 update. So for IR, actually we have a kind of the weapons in our hand. So this is kind of infinity gauntlet of intervention. So it's not just like a click, so easy. So for example, we have C-TACE, we have DEP-TACE, we have Y90, we have HAIC, we have ablation. And also I think the most powerful is the combination treatment and the sequential approach, like the Professor Liu mentioned before. So we know that for the lipidotace, for the large tumor or multinodule, actually these two kinds of patients own the worst survival outcome. So how to improve the survival and the treatment response? And we also know that for the large tumor, if the patient can get the good response or complete response in the first 1 or 2 TACE treatment, actually the patient had the longest survival or progression survival. But for the large tumor and the multiple nodule, actually still, this kind of patient has the worst outcome. So this is Taiwan's developed 711 criteria. You can see that for the 11, if the tumor number or size, the sum of these two, more than 11, actually the survival and the progression, recurrence-free survival is the worst. So it's in the old days, we only perform C-TACE for this big tumor. Of course, I know Professor Zheng can do the ethanol TACE and it works very well, but we don't do that. So we only do C-TACE. So C-TACE, 2 sequential C-TACE still, the tumor grow fast. So actually, and if you add the embolizer amount to 20, actually you will increase the risk of pneumonitis and also the cerebral embolization. So even the C-TACE is the mainstay, but is it enough? This shows the unmet need for the conventional TACE remains, such as we need a more powerful weapon, have a consistent or continuous drug delivery and the liver toxicity. So that's why the DEP-TACE developed. As we know, the DEP-TACE actually is control the release of the high concentration cytotoxic agent to the tumor without the effect, the most of the systemic. So the sustain can be continued to up to 7 days. So some kinds of the beads, such as Hipposphere, has a kind of the power of the conformability, can squeeze into the small vessels. That's one of the specific characteristics of this kind of beads. So we know there are lots of the study compare with the C-TACE and DEP-TACE. This is one of the famous negative study from Japan. So, but we know that Japan doctor perform C-TACE very well. But when we look at the data, you can see that most of the occasion, the tumor is only 1 or 2 tumor, and the tumor size is very small, less than 3 centimeters. I think that's why the study failed. One possible reason, and they use 100 to 300 micrometer beads. So this is the milestone study, Precision 5, the most largest cohort study right now, but it's positive. But the positive is from the, it's not from the survival, it's from the toxicity. So they found that in the advanced disease, actually the DEP-TACE had less liver toxicity compared with C-TACE. Korea data, similar advanced disease patients, but they achieved the higher time to progression and the median overall survival in their study. So how about the big tumor and the multifocal size, HCC? This study, small cohort study shows that the better observed response rate in large tumor and the multinodule in the DEP-TACE group. The below one is from China. So you can see that compared with the C-test and DEP test, actually the response rate at 6 months is better in the DEP test group, and the survival were better as well. So meta-analysis is the kind of the equivocal result. Some meta-analysis show that actually DEP test can have a better tumor response and better overall survival as compared with the C-test. But the most recent meta-analysis from Korea shows that this kind of the similar result. But the one thing we can sure that is the DEP test has a lot less liver toxicity as compared with the conventional test. So this is a very good study from Taiwan's many outstanding experts in this room. So I only want to mention that in the DEP test, we can find that actually the change of TRAPU score and LB grade you cannot notice that. But in conventional tests, maybe after sequential conventional tests, actually the patient's liver function and TRAPU grade may upgrade. So I think this is one of the most benefit of the DEP test. So in this high bilirubin level patient, initially it's 2, but it's up to 11 multinodule. Actually, in this kind of case, we try, if the doctor asks us to do taste, we perform the number one choice is the DEP test. So after one time of the DEP test, the tumor, most of the tumor show the devascularization, but with some the tumor you cannot treat very well. Actually, you can add another local regional therapy such as the ablation. So after 2 times of DEP test, actually the liver function did not change a lot. So the TLCA, the intermediate stage, the guidelines just published in August. There is one statement that the efficacy DEP test is comparable to C test, and the adverse reaction is low. So this is reimbursed criteria. I will skip that. So how to optimize? So I think the number one is patient selection. We need to follow some kind of consensus of technique guidance. We need to use a good image during the procedure. And combination therapy and integrate with systemic therapy is a trend. So the low LB score, low tumor burden, low echo status are good patients for the DEP test. But some Japan experts say that, if the tumor, the DEP test only can put in the green zone, 3 to 6 centimeter tumor and 4 to 6 nodules. But I think it's not true. For example, this is a good candidate for DEP test, peripheral location, hypervascular with capture. So this kind tumor, if you use the DEP test carefully, actually you can achieve a very good outcome. And for the tumor up to the large tumor burden, more than beyond up to 11, actually nowadays when I do the test, I will choose the DEP test if the patient have the money or it can fit the reimbursed criteria. So if the patient is a TRAPU B, LB2, you can do sequential actually. And for the multiple nodule large tumor burden, you can treat the tumor dominant side and combine with the systemic therapies. So the technical recommendation is quite important. Taiwan's recommendation, I think, is very good. We enroll the Portovan case. We expand the patient selection. So in this kind of 3 tumor, actually you need to do the subsegmental selection and the embolization. Choose the smaller beads. The sweet spot is 100 right now, nowadays. So the endpoint is important. The prong tree important is the endpoint is you want to achieve. Which means that you still can keep the segmental or lobar artery patent, but the feeders should be stasis. And the vascular rate is another endpoint, which means that nearly all the vessel was occluded. So near 25% patient, hypervascular tumor patient, you can find that. Just add some gel foam, Lipiodol, or large beads, you can stop the vascular rate. And the contrast saturation in the dry CT, even cone beam, or if you have a hybrid angio CT, is kind of predictor of a short-term tumor response. So we do that in every cases of the depth test. If you achieve the G5, which means 100 contrast saturation of the margin, actually the recurrence rate is quite low, and you can achieve the complete response in those kind of the patients. So to emphasize, cone beam CT is quite important. It's quite useful. You can find that there is some defect you did not embolize. So you need to find, for this kind of case, we all know that there's kind of extrahepatic supply from inferior phrenic artery, and we do the embolization. Then you can achieve, we use, for the big tumor, we frequently use 2 vial, sometimes 3 vial of the depth test. But you may ask, how about the insurance coverage, just 1 vial in 1 session? So 1 vial, we will talk about, talk to the patient, 1 vial, you don't need to pay. But another 2 or 1 vial, you need to pay for that. So this is kind of a combination. Yeah, so sequential treatment is useful. So for in the CT follow-up after the depth test, the necrotic part will make the viable part pop out. So you can ablate it or embolize these kind of tumors. So follow up the Lipiodol test after depth test have been proved to increase the complete response rate. This is a paper from the Professor Guang in Asan. So they in the large tumor, they do the depth test first. If there is viable, they follow the Lipiodol test. Actually, you can increase the complete response rate. Like this multi-nodule, after 1 session of depth test is still viable, and very fine feeders such as that. So we choose the Lipiodol test, and you can achieve the complete response. So China doctor, because there is some challenge in depth test, we all know that the beads may not go to the sinusoid or to occlude the blood supply from portal vein, but Lipiodol can do that. So the China doctor combine in 2 sessions. They do the Lipiodol first to outline the margin, to feel the muscle part of the tumor. Then they deliver the beads to this kind of combination in 1 session. So the result is quite good, and this kind of technique have been listed in their IR HCC treatment guideline. So by combining this technique, you can achieve better response and median progression-free survival and OS. So currently, there's recent trials combine TACE and the systemic therapy. All the trials show that the combination group have the better median progression-free survival. And the TACE-L use lenvatinib combined with the TAC. Also, you can see amazing complete response rate near 60%. So combination with not only immune IO, or you can also combine with the TKI such as lenvatinib. So this patient have a left lobe tumor with vascular invasion, but however, our surgeons still do the resection. They do the left lobectomy. The initial outcome is good, but you can observe that the FU level gradually increase. And the follow-up CT 1 day showed the multiple recurrent nodules. So the GI doctor prescribed lenvatinib first. Then they ask us to do the embolization. You can see the complete response for 4 months. But because there is the vascular invasion, so quickly there's a recurrence. So we do another 3 sessions of the details. So if I try to search some articles talking about the depth test combined with IO, and it's compare 2 group. It's not single arm, it's 2 arm. So this is a paper from China. So they combine the depth test plus the lenvatinib and the PD-1 inhibitor. Actually, still the combination group has a good overall survival rate and the disease-free survival. So this is my last slide. How to convince your colleague, especially the oncologists or GI doctors. Actually, I think many doctors in this room already know that. I always talk about, it's a similar outcome, but the less toxicity. And if we want to treat a larger tumor, actually, we can, by using drug-eluting BZ, we can deliver higher anti-cancer drug and less liver toxicity of the patient. So to summarize my talk, is the patient selection matters most. Actually, the DEP test and C test is comparable efficacy, better, but it's at better tolerability. So technique determines success. So we need to follow Taiwan experts guideline, led by our president Bi Zhang. So the future direction is integration and the combination. Thank you.